My name is Elisabet Hagert and I am a consultant hand and wrist surgeon at Aspetar Orthopedic and Sports Medicine Hospital in Doha, Qatar. I have no conflicts of interest. I would like to thank you for the invitation to speak to you today about Lacertus syndrome. As we all know, carpal tunnel syndrome is one of the most common surgical procedures that we see in hand surgery, entailing numbness in the median innervated fingers. We have about 80 to 90% success rate at surgery, which means, however, we have about 10 to 20% failed surgery. Bland and co-workers at the NHS Foundation published their retrospective review on 6,263 carpal tunnel releases in 2012. They found that 77% of their patients had good to excellent outcomes. However, 10 to 20% are failures. So we have to ask ourselves, was the surgery correctly done, or was the diagnosis correct? This is Professor Don Lalonde. Professor Don Lalonde had persistent symptoms after his own carpal tunnel release. These are his words. I had positive nerve conduction studies and classic carpal tunnel syndrome symptoms. I went through my first wide-awake carpal tunnel release in 2006, which made my symptoms better, but I still had residual numbness in my left long and ring fingers. I had a redo carpal tunnel release under general anesthesia in 2007 with no difference with regard to my symptoms. 4 years later, in 2011, at the Canadian Society of Hand Therapy meeting, I met Dr. Elisabet Hagert of Stockholm, who was also speaking, and that was when I first learned of Lacertus syndrome. We've recently published on our 10-year experience of the Lacertus syndrome. We identified 388 patients who had undergone Lacertus release. Of these, 275 were isolated median nerve decompressions, as in Lacertus and/or carpal tunnel syndromes. 25% of our patients had a so-called double crush syndrome, entailing a simultaneous compression of the median nerve at the level of the Lacertus and the carpal tunnel. 12.7% of our patients had prior failed carpal tunnel release. So what is Lacertus syndrome? Well, Lacertus syndrome is like carpal tunnel, but for the elbow. At the wrist, we have the carpal ligament, which is a fibrous band compressing the median nerve. Whereas at the elbow, we have the Lacertus fibrosus or the bicipital aponeurosis, which is a fibrous band compressing the median nerve. If we look at the symptoms of Lacertus syndrome, we found that in our 275 released patients, the most common symptom in patients with a double crush with both carpal tunnel and Lacertus syndrome was numbness within the median nerve territory. However, in patients with isolated Lacertus syndrome, the most common symptoms were that of loss of hand strength and a complaint of loss of endurance or a sense of fatigue in the hand. Other common symptoms in about 20 to 40% of our patients included forearm pain, a loss of hand proprioception, as in feeling as though they would drop things and be clumsy without recognizing the clumsiness, or intrinsic muscle cramps when working. The intrinsic muscle cramps are a sign of overloading the ulnar nerve innervated muscles of the hand due to loss of power in the median nerve innervated extrinsics. So how do you set the diagnosis of Lacertus syndrome? Well, Lacertus syndrome is a dynamic nerve compression, which is also called a Sunderland Stage 0 by McKinnon and co-workers. Since it's a dynamic nerve compression, it means that there is no axonal injury, but rather changes in axonal transport. This means that the specificity in EMG and nerve conduction studies will be very low as about 30% in some publications. We should also remember that nerve conduction studies and EMG are passive studies. and Lacertus syndrome is a dynamic nerve compression and a dynamic diagnosis. As compared to nerve conduction studies, in a muscle testing algorithm in a blinded controlled study published in 2018, it was found that muscle testing has an 88 to 93% sensitivity and specificity for diagnosing nerve compressions proximal of the carpal tunnel. We are all used to using muscle testing to diagnose patients with brachial plexus trauma or disorders, as well as patients with suspected cervical root compressions. However, when it comes to peripheral nerve compressions, we most often use sensory testing or various provocative maneuvers to elicit pain or elicit numbness. But we must remember that the majority of peripheral nerves are both motor and sensory, and as such, we should examine for both. If we look at the axonal organization of the median nerve at the level of the Lacertus fibrosis, we will find that the most superficial axons under the Lacertus are those to the FCR, the FPL, and the FTP2, and thus these are the muscles that we must examine to identify Lacertus syndrome. This is Professor Don Lalonde and his preoperative muscle testing, revealing a weak left FCR, FPL, and FTP2. Remember that he had gone through 2 prior carpal tunnel releases in his left hand without resolution of the symptoms. Always compare with the power in the contralateral side.
And keep your little finger flexed. So on this side, keep your index finger flexed, and flex. And flex. And flex again.
The next test, after testing for weakness in median innervated muscle, is to do the scratch collapse test. The scratch collapse test was first defined by Susan McKinnon and co-workers in 2008. It involves a physical irritant or a scratch of the suspected area of injury or nerve compression. If positive, the result is a temporary loss of voluntary muscle contraction. The theory behind the scratch collapse test is the so-called cutaneous silent period. The cutaneous silent period is a period of inhibition in tonic voluntary muscle activity due to painful cutaneous stimulus, as is visible on EMG. This is thought to be mediated by A delta nerve fibers, generally thought as a protective inhibitory spinal reflex by withdrawal of a limb from a painful stimuli. In a recent publication in Science in 2019, the researchers published their findings of a new dermal epidermal mesh of specialized Schwann cells. These Schwann cells are found to convey noxious thermal and mechanical stimuli from the skin and transmit nociceptive information to the afferent nerve, which is likely also part of the explanation of the scratch collapse test. So when you do the scratch collapse test, you can use various types of irritants. You can, for instance, either touch or swipe with a finger, such as over the carpal tunnel. If you have a patient with neuropathic pain or hyperesthesia, you can fan with your hand or even blow air over the area that is sensitive. Finally, in nerves that are more deeply located, for instance, the radial or the median nerve in the forearm, you can apply a deep pressure. So we call it the scratch collapse test, but it should perhaps rather be called a sensory collapse test, as various types of sensations can be applied that will result in a collapse of the arm. So when can't you use scratch collapse test? while for instance in patients with a brachial plexus injury. In patients with a rotator cuff injury, you can't use the scratch collapse test with external rotation in the shoulder. In these instances, I prefer to test the strength of the triceps. And finally, in patients with cognitive issues, your patient has to be able to cooperate when doing the scratch collapse test. When you perform the scratch collapse test, you want the patient to be seated robustly, have the arms in line with the body, the shoulders adducted, elbows at 90 degrees of flexion, the forearms in neutral. You want to do bilateral testing, and you want to scratch the healthy side first for control. This example is of a carpenter with bilateral carpal tunnel syndromes. As you can see, he is very strong in external rotation, whereas when you scratch over the carpal tunnel, he can no longer resist. This is what the scratch collapse test looks like in a patient with a right Lacertus syndrome. Scratching over the healthy side, the patient is strong. Scratching over the compressed side, he cannot resist. The final aspect of diagnosis is pain over the median nerve at the proximal edge of the Lacertus fibrosis. Well, what about sensory symptoms and the Lacertus syndrome? Well, remember, sensory symptoms are not always present. In our cohort of 275 patients, we found that in isolated cases of Lacertus syndrome, only 10% of our patients complained of numbness or loss of sensation in the hand. If you want to test for sensory symptoms, remember to test the sensation within the palmar cutaneous branch of the median nerve, as any loss of sensation within this area of the median nerve will be due to a more proximal median nerve compression and not found in carpal tunnel syndromes. Of course, if you have a patient with a double crush, carpal tunnel, and Lacertus syndrome, you may find numbness within the entire median innervated territory of the hand, as well as positive Tinel's and Phelan's test. The Lacertus syndrome surgery, well, the traditional release of proximal median nerve compressions, or so-called pronator syndromes, used to be approached through a very large S-shaped incision from the distal upper arm to the mid-forearm. However, our preferred approach is a mini-invasive approach with division of the Lacertus fibrosis alone. So what is the rationale behind using a release of the Lacertus fibrosis alone? Well, we recently published our study on the effect of Lacertus fibrosis release on perineural pressure of the median nerve at the elbow. It was a cadaveric study where we examined the perineural pressure of the median nerve before and after division of the Lacertus fibrosis alone. And what we found was that we had more than 80% decrease in median nerve pressure at the elbow following release of the Lacertus fibrosis. This is what it looks like. When you're doing a Lacertus syndrome surgery, you should preferably do it using Lalonde or wide-awake hand surgery. Start by doing preoperative muscle testing.
Can I ask you to please flex your thumb?
And keep it flexed.
And keep it flexed.
Resist.
And resist.
And again.
And again.
And resist.
And resist.
And flex your finger.
And flex your finger.
And resist.
And resist.
And again, resist.
And again, resist.
The surgery is usually done in Lalonde anesthesia. I prefer to use 1% lidocaine with epinephrine. I infiltrate between 20 to 30 cc's of local anesthesia on the ulnar-volar aspect of the elbow and the forearm, as shown in this graphic. The surgery is usually performed through an ulnar-volar transverse skin incision, either right at the antecubital fossa or slightly distally.
We see nerve branches. And we use bipolar cautery as necessary. The first landmark defined is the fascia pronator
teres muscle.
It is bluntly dissected, both superficial and deep. And this is the clear shiny layer you can see here. Using blunt scissors, this layer is cut so that the fascia of the biceps aponeurosis can be visualized underneath. Gently cutting and spreading. Here in this photo, the white thick layer of the biceps aponeurosis can be visualized and is carefully dissected both superficially and deep before cutting, as the median nerve is often right under this layer. In other cases, there's often a layer of muscle superficial to the median nerve, which can be released as well. In this video, we are cutting the aponeurosis along its course. And our goal is to cut the aponeurosis in its entirety, as to release the median nerve, which is entrapped underneath. Afterwards, we palpate the area both proximally and distally along the course of the median nerve to ensure that we have adequate release. And occasionally we require further release of the aponeurosis or of the FDS sling. The nice thing about doing this procedure wide awake with a cooperative patient is that after we have performed our release, we can test the patient intraoperatively by asking him to again flex the index finger FDP against our resistance. And in this case, the patient has immediate return of his strength. We also test the FPL tendon against resistance.
So this is what it looks like in that same patient immediately after release.
And flex your fingers. And resist with the index finger. And flex your thumb again. And resist. Perfect. Well done.
And this is what it looks like in Professor Lalonde immediately after his left Lacertus release.
You can't do it. It's just
Flex your thumb and keep it flexed. Flex your thumb and keep it flexed.
The reason for the immediate return of power is the fact that this is a dynamic nerve compression without axonal injury, or a so-called Sunderland stage 0. If you want to see more about the surgical technique, I recommend you to look at the video on viewmedi.com. Once you start feeling comfortable about doing Lacertus release, you can start doing an even more minimally invasive technique. I prefer to do it these days using 20 cc's lidocaine with epinephrine, a 1.5 to a 2 centimeter small incision just over the Lacertus fibrosus, which is about 4 centimeters distal of the antecubital fossa. This way you can just do a blunt dissection straight down to the Lacertus fibrosus and release it. My colleague Thomas Appar of France has also described using ultrasound-guided Lacertus release. This is not a technique I'm familiar with myself, but I know that he is using it as a regular treatment for Lacertus release, allowing it to be done in office. If we look at the outcomes of our 275 operated patients and our demographics, we found that we had an equal division between women and men. The average age of our patients was 47. The dominant arm was affected in 67% of cases, and 26 of our patients were manual workers. Of our patients, 136 completed both pre- and post-operative DASH and visual analog scale scores. We found a significant improvement in both quick DASH, work DASH, and activity dash scores, where our average preoperative quick dash score was 34.4 and post-op 12.4. Evaluating the subjective satisfaction with surgery, we had 88% good to excellent outcomes. Well, what about Pronator Syndrome? How can we distinguish between Lacertus Syndrome and Pronator Syndrome? Are they different or are they the same? Once again, looking at our 275 Lacertus releases, we did the surgical release in 91% using wide awake or Lalonde anesthesia. Of these, 99.2% of our patients had immediate intraoperative return of power within the median innervated muscles using Lacertus release alone. Only 2 of our patients had an intraoperative finding of a median nerve that was within the pronator muscles or a traditional Pronator syndrome. In other words, in our case series of 275 patients, a so-called Pronator syndrome is exceedingly rare. What's interesting to note, however, is that more than 80% of our patients described that they were working with their arms pronated for more than 5 hours per working day. So our conclusion is that proximal median nerve compressions are not Pronator syndromes, but they are rather syndromes of pronation. In a recent publication in Hand in March of 2023, Klein and co-workers described their experience with proximal median nerve entrapment by the Lacertus fibrosis. Their conclusion was that when you start actively examining all of your patients with muscle testing, testing for strength in the FCR, FPL, and the FTP2, especially in patients with signs of carpal tunnel syndrome, you will start finding the Lacertus syndrome. They reported that after introducing muscle testing in their clinical setting, they had a significant increase in the number of Lacertus syndrome cases, and they found Lacertus syndrome in patients with 85% prior failed carpal tunnel syndromes. When examining patients up to 5 years after Lacertus release, all of their patients remained symptom-free. You should look for Lacertus syndrome in patients with carpal tunnel syndrome or who haven't gotten better after carpal tunnel release, such as in this professional cellist of the Stockholm Philharmonic Orchestra, who came to me after a prior carpal tunnel release, but still complaining of a loss of fatigue, loss of endurance, loss of proprioception, which affected his ability to work as a cellist. You should look for Lacertus syndrome in patients complaining of loss of dexterity and a loss of hand endurance. In patients with work that entails a pronated forearm and repeated finger motions, for instance, musicians, computer workers, surgeons, lab techs, dentists. And you should look for Lacertus syndrome in patients with a negative EMG or nerve conduction study, but with obvious hand pain or a loss of hand function. If you're interested in nerve compression syndromes, I publish quite frequently on my Instagram and LinkedIn accounts, as well as on my YouTube channel. I would like to extend a huge thank you to my father, Professor Carl-Göran Hagert, a 2019 IFSSH pioneer of hand surgery, who taught me about manual muscle testing and looking for proximal median nerve compressions. And I would also like to thank my amazing surgical team at Aspetar Orthopedic and Sports Medicine Hospital in Doha, Qatar. Thank you once again for the opportunity to speak to you.